Also, I would like to thank you all for taking the time out from your heavy schedule and marking our program with your glorious presence. Thank you for joining with us this evening, and also don't forget to subscribe our YouTube channel so you can always be in touch with our program even in the future. For now, I would like to step forward to inaugurate today's session, and also I would like to notify you all that we will be having our discussion session at the end of the webinar. So if you get any queries in between the session, then just drop it on our comment section. We will get back to you later on. Today we have with us a very special guest all the way from USA, Dr. Richard Hom, and he will be talking on topic public health vision programs. Before he begins, I would like to give his general introduction. Dr. Richard is an OD, PhD, and MPA. He is also the optometric director at Anthem Incorporation. Also, he is an adjunct associate professor in optometry at the New England College of Optometry. Furthermore, he is also a diplomat in public health and environmental vision of the American Academy of Optometry. I welcome you, Dr. Richard, on behalf of Mero Eye Foundation and all our participants. So now you can start sharing your screen, Doctor.
Okay. Well, thank you very much for the invitation. First of all, these are my personal opinions, and there's no funding. This is all privately done, so there's no what do you call disclaimer necessary. So we're going to be talking a little bit about early detection of diabetic retinopathy, and usually the early detection of diabetic retinopathy is a public health concern because there's a lot of people who have diabetes, and there's a lot of people who could have diabetic retinopathy. And what we want to do is make sure that all the people who need the care are given immediate care and interventions such as surgery or medicine, and all the people who have the disease but are not yet needing treatment can be seen at a different time, not just immediately, because usually there are many more diabetes patients than there are doctors or any type of thing. So we need to make sure that we send the most needy people to make sure they save the vision to the right person who can give them care. It could be a person who can give them glasses or to watch over them, but taking pictures a year, or they can be needing immediate medical attention in 1 month or less. Again, we'll just give you with special emphasis is the use of public health principles. In this particular posturing of the program, I've used the principles here in the United States for at least 8 years in just designing programs that identify people with diabetes and diabetic retinopathy and being able to sort them out and give them and send them to the right place. So public health is a little different. Sometimes we think that, what is public health and, why should we care? Well, usually public health is related to the whole population or regional population. What is their health? And how can we as a society, which is the collective individuals in that region, how can we do something to make sure that people can be healthy? So usually public health is concerned with not only just the eyes, it's the complete makeup of the person. And we also want to emphasize, once we consider the whole person, how can we prevent diseases? That's what public health is. And usually public health and preventing disease is usually a very large program. It's over a country or region. And usually it's beyond the means of a single individual. Usually it's government sponsored. It may be sponsored by private foundations, but again, it's a large enough program that it needs a group of people. And public health means is that also you can provide the information and the evidence necessary to actually have it funded. So that's what public health is about. So what we're trying to do in public health is try to change behaviors. And this is just a triangle. You can look at it yourself, but we can either, at the very top is how can we apply a public health program to influence individuals? And we're, of course, have to be consider the environment, what's the social norms and things of that sort. How do we send messages out that could change behavior? And who do we ask to do that change in behavior, which is the agent? Now, the mission of public health is, from the World Health Organization, is trying to provide the maximum benefit to the largest number of people based on the resources you have. And in the Nepal Public Health Foundation is, it's a right and responsibility. So this is usually a case, but because it's a government funding, it is sensitive to government priorities. And a lot of times public health isn't necessarily high on it. But again, it is for the maximum benefit of the largest number of people, with constraint being whatever the resources are available or has been given. Now, one of the aspects of public health, which is particularly in my interest, is surveillance. That's one of the key things is how do we, if we know that there is a problem, how can we know that it's there? And one way to know it's there is to actually create a program that can identify the condition early enough so that you can say, well, these are the number of people who have the condition, and these are the number of people that need care. And by counting the number of people, and you do it from year to year, you can say, this is how serious a problem is and how it changes. Is it getting worse? Is it stable? And what we use this, all this information is for, so that we can actually create a form of a program so that we can evaluate its effectiveness once we roll it out, and then we can change it. In the case of diabetes and diabetic eye diseases, we would like to, when you do a identification of diabetes eye disease, you're also assessing the general well-being of the person, because not only you just look into the eye for diabetes, you can say is how well you see. And during that process, you can say, well, if you have 100 people, you can say that so many people have diabetes of the eye or not, but you can also say how many people have 20/20 vision or how many people need glasses, because that's part of the process. You're there already, you can ask that question. So actually a lot of public health data collection can be multiple purposes, multiple outcomes. And from one particular study, you can actually design different types of programs based on the information gathered. So by designing how you gather the information, you can feed further studies instead of trying to say, oh, I forgot to do that. If you think about what you want to do ahead of time, you can use the same data over and over again. So this is my personal belief, why it's important. Of course, in the case of the United States, I believe that public health is generally not only completely public funded, but also needs private partnership. We call it public-private partnership. The private sector could be doctors, it could be hospitals, it could be membership organizations, and they are differentiated from the public, which is usually the government. The government in general don't have all the kinds of people that can make programs work. So usually what they do is if they do fund something, they look for somebody that can actually do the work. And usually they will contract with a group of providers or a organization to actually do the work. Because again, governments can give the money, but they rarely have the personnel or expertise to actually deliver the project and keep it going on. So that's what we call public-private partnerships. And by forming those public-private partnerships, you can actually start to think about really delivering public health and measuring it and making sure that it actually is a force that could create legislation or further budgetary allocations towards that purpose. In the case of diabetes, we're going to apply the principles of surveillance, and usually means is that we're going to try to see how many new cases. We call that incidence. What's the incidence rate of new cases of diabetes and diabetic retinopathy? That means every year, every time we diagnose a new case, that's called incidence, with the new number of new cases. And when you can count the number of new cases, then you can say is how serious the problem is, because it's one thing to say that there are so many people who have diabetes out of 100, but that's a slice in time. What we're looking for is over a year's time, how many new cases. So that's called incidence. And when you say this is how many people are that have the disease, including the new ones, that's called prevalence. So sometimes it's Sometimes it's confused, incidence versus prevalence. In this case where we say how many new cases, that's incident. And so when we talk about how many people have the condition in a particular environment and proportion, that's usually the prevalence. Now, usually the prevalence could be the number of people per 100,000, or it could be a percentage of the people. A lot of times when you have different size regions that you're trying to compare, it's sometimes better to say, well, we have the prevalence of a condition is 10 out of 100,000 or 10 out of 10,000. That would be easier to compare one country with another country. Another aspect of how we can describe the use of public health, of course, is how you describe the natural history of diabetic retinopathy. If you did not do any treatment, what's going to happen if you, what happens to that patient? Well, a certain number of patients over a certain number of time will go blind, and you want to know exactly how certain is that. Now, usually the studies that we read in the journals may not apply to your local population or culture or geographic area. And so therefore, sometimes it's good to read other papers, but sometimes you'd like to get some local information about the characteristics of, do people who don't get treated with diabetic retinopathy, do they go blind, and how often? And then lastly, at the very bottom is, where are they? A lot of times the retinopathy could be in different regions of the area. And, if you can say, well, this region does a better job than the other. In the United States, we actually count diabetes and diabetic retinopathy in each county, in each state. So we can actually get pretty, granular, we call it, about how deep we can start to describe where's the problem and how much what's the obstacles. So once we identify that there's a difference in different areas, why is one area different from the other? And lastly, of course, is what's the cost and how can we justify the cost? So in one of the things that we do is, because cost is so difficult, whether it's a drug, whether it's a medical device, whether it's an operation, what we usually have to decide is, what the World Health Organization has created is something called quality of life years, QoLIS. And that's the concept here is that it is the ratio in is really about how much your life is affected. So QoLIS is like if you had a QoLIS of 1.0, that means that you probably you have no barriers to having a quality life. Now, if you're blind, you could say the QoLIS is 0.5 because that diminishes your quality of life, and so therefore you would count that as less. Now, the QoLIS between 0.5 means that the cost associated with that is very high, and if the QoLIS is very is very low, now if it's very high, then what happens is that it doesn't cost as much because you're already at a high level of living. So that's the difference. In the United States, related to diabetes, the cost of QoLIS is for diabetic retinopathy is about $3,300. And what we do is we say, well, if I had to compare the cost of diabetic retinopathy surveillance against, say, glaucoma or whether it's cataract surgery, you can compare which is where the biggest bang for the dollar. So let's suppose you had $100 and you have to say, where do I spend it? I probably don't have enough money to do all three or all four or five, but let me try to dedicate the money into the best place with the biggest bang for the buck, we call it, has the biggest effect. And practically every organization tends to do this. So that's how we choose which public health program to fund and which one we say, we have to do it next year. So this is this is actually a very good graph. It's kind of like a graphical explanation of how you would do a cost, benefit, and effectiveness analysis. And as you can see is that on the upper right-hand corner, if you have good value for your money, so it's below the axis, you can increase the outcomes, and so long the outcomes increase, it doesn't done at the cost of higher expenses. So one of the things that we want to do in public health is make sure is we get the maximum outcome with the least cost, and that's over to the lower right-hand corner. And actually at the lower, in the questionable area, in the dominant area, you usually have very low cost outcome, but that's usually a uncommon circumstance. Usually you're trying to balance money and you're trying to get the best value for money. So in the questionable area, you're actually trying to compare different types of approaches. So in the process of surveillance is that you want to be able to, see who needs to be watched, then collect the data, and then try to, if you're different places, you got to try to consolidate data from the different places so you can say, well, this is the country's prevalence of a problem. So you can start to collect data from all the different areas, and then you create a report that says, okay, this is the problem, this is the how common the problem is, how big a problem is, this is what the cost would be compared to others, and this is the reason why you should fund my program and not that. And then after you create the program, do the research, you have to actually distribute the report. And usually that's done to the right audience. Usually it's legislators, usually it's local authorities. It could be doctors also to say, hey, this is a problem, we should actually dedicate some time and resources to it. So let's take the case of diabetes. Globally, it's 5.4%, and in India, and I'm going to guess probably in Nepal is very similar, it's a little bit more. Impaired glucose tolerance is actually usually 50% or even 100% more than actual cases of diabetes. So when we talk about the diabetes problem, there's an immediate one, because those are the ones who actually have the disease, and people who have impaired glucose tolerance, those are the people who are at risk for converting the disease. So it's useful to know both numbers. And in India, the rate of diabetes is much higher, could be up to 16% considered by news reports, not by any published reports. So we do know that if we, there's age distribution for diabetic retinopathy. And so therefore, as you can see, practically every author kind of says that as you get older, the risk or the commonness or prevalence of diabetes is higher. So even though you may start diabetes at 30 or even earlier, you usually have to have 15, 20, almost 30 years of diabetes before you have actual diabetic retinopathy. So again, it's according to age. So that comes this comes to the actual, what are the medical reasons for trying to detect diabetes and diabetic retinopathy ahead of time? Well, it turns out if you can detect diabetes early enough, then the systemic conditions or the seriousness of the disease can be reduced. And in this particular case, if you can identify people with diabetes and diabetic retinopathy early enough, you can actually prevent the most severe form of diabetic retinopathy called complete loss of vision or blindness. And so therefore, earlier detection of diabetes, as soon as you can identify them and apply some of the systemic corrections, as well as better attention to diet and exercise, you can actually lengthen the time where you can have the worst consequences. So generally, diabetes retinopathy is about 20 years before you start having a lot of people having the problem. And some people, if you want to stretch that and say, okay, I have diabetes, I don't want to have the eye problems until 30 or 40 years. Well, the only way to do that is to identify the people early enough and start to do corrective prevention, such as diet, appropriate medication, exercise. And then what happens is, instead of being blind in 20 years, you might be blind in 40 years. Again, you can't cure necessarily diabetes at this time, but what you can do is, the role of the optometrist is to ensure that the person will actually outlive the disease. In other words, they get to have, the goal is to make sure that the person gets to see until their natural death arrives. And it's a defeat on our part if we have any person that goes blind before they die. So the seriousness is that any type of diabetic retinopathy, once you see it, there's a high chance that there's going to be some significant vision loss. And there are more than one type of problems with diabetic retinopathy. There's bleeding. There's also macular edema, which is probably the most important finding, more than the vascular or bleeding, because macular edema actually is at the macula, and any effect there will change or harm vision faster than the other types of changes, such as bleeding. So, what's important for optometrists is in our daily practice, let's say it's not part of our public health, by looking in the eye, and if you can see changes and the person says, oh, I don't have diabetes, well, you might be in that situation where you might be able to say, hey, I think that you will become diabetic. You should probably do something now. And if you can do corrections before you actually take the medicine, such as weight change, careful eating, exercise, you can actually say, well, instead of being diagnosed with diabetes in 4 or 5 years, you can say, well, it might come in 15 because I've changed my lifestyle, and I can actually say, I can forestall the eventual diagnosis of diabetes. Now, it's very difficult to actually say, oh, I'm not going to have diabetes. Well, actually, I've met many people from India, and not necessarily Nepal, but India. And I know people who are strict vegetarians. Now, I'm not saying that's the only way to do it, but I know people, when I've seen them, I said, they said, oh, I've had 40 years of diabetes. I look in the back of the eye and say, yeah, there's minor changes, but certainly not the severe signs I would see. Well, that's a situation we're talking about. You can identify these vascular changes ahead of the actual diabetes. And the way we could do that in the part of optometrists is either part of a surveillance program or in your offices to do a photograph. Now, the good thing about photograph is it usually means that a lot of, like in Latin America, there are certain laws that prevent an optometrist from using even an ophthalmoscope. Well, one way you can get around that is take a picture. And actually, the picture is kind of nice because you can actually say, okay, I can look at the picture later on and say, okay, I see something I missed. And also sometimes the non-mydriatic camera can record an image of the eye without dilating. And usually when you use an ophthalmoscope or a 90 diopter lens, it's sometimes difficult to see the complete picture of the back of the eye. And sometimes the photograph is actually even better than retinal photography. In this case of COVID pandemic, we may not want to get close to a patient because ophthalmoscopy or even any other type of thing, you're within 2 feet of the patient. And research shows that if you're staying within more than a minute, closer than 2 feet with a patient, there's a high chance that you're going to get a lot of virus. So in order to stay further away from the patient, outside that 2 feet danger zone, that's what retinal photography does. You can put the patient at the other side of the headrest, and you're probably closer about 2 feet, and sometimes 3 feet, depending on what type of equipment. So in general, photography actually is pretty good. And it's almost as good as looking into the eye and say, hey, that's exactly what diabetic retinopathy. So photography actually, if you have 2 photographs per eye and you can read it, it's as good as looking at the eye. So studies show that is as good as a clinical environment. Now, you might hear stories that artificial intelligence can increase that. Well, sure, but the thing is that a lot of times you can't get a good photograph if you're depending on using artificial intelligence, because when you look at a photograph, you can kind of guess what it looks like, and that's a yes or no. And in artificial intelligence, the integrity of the photograph has to be much better because they're using a computer to read all of the pixels of a photograph, and that's how they determine whether something is wrong. But you as in the eye can say, hey, you don't need as good of a picture a lot of times, and if the picture is iffy, of course, you can actually say, hey, that is yes or no. And that means that you can be able to make a decision better sometimes than in artificial intelligence. So don't misjudge the value of the photograph by itself and versus the artificial intelligence. I believe that the human eye will always be as good as a computer in certain circumstances. So, when we talk about photographs, there was a lot of concern of, can it be as good as the old-fashioned taking a picture? You might have known pictures done 20 years ago, 30 years ago using film. You used to take 7 pictures of the eye and use software to put them together. We call it a collage, or stitch them together so they can see the complete back of the eye. And that's what we call the gold standard, and it still is the gold standard. 7 images of the back of the eye, in both a film camera, and what we compare with a smartphone or a other type of digital photograph is that we may need only 1 or 2 images rather than 7. Now, we found out that the 1 or 2 images is almost as good as the 7 images on the film. So that's why using a digital camera even a smartphone, and being able to store that data and then therefore send it for public health data collection and categorization is very good. And not only that, it's a great way for you to learn how to assess the back of the eye. Now, of course, with the value of photograph, and I'm not sure yet, I haven't found any research topics in Nepal directly, but there are studies and for Bangladesh and India, and here's a study that says that with using photographs, they found that the prevalence of diabetic retinopathy was about 33%, very similar to generally other published studies in that area. And also that, again, in this particular study, the last one, that says that if you can detect it early enough, and usually a picture, by taking a picture, you actually show the patient here, these are the changes that I see in the back of the eye. They're the signs of diabetes and diabetes disease of the eye. And actually, the pictures can actually help you influence, persuade a patient to say, hey, you know what is it? There's, I can change my life. Now, of course, you have to have a person that's willing to change, able to change, and that sort of thing. But if there is a person who's willing and able to change, the evidence of a photograph may be enough to say, hey, I think I would like to save my vision. Now, the good thing about digital photography is that usually it's a small camera and it's easily, situated, doesn't take a lot of space, and it's great for actually regularly screening a person, because you can actually do it 4 times a year. You can do it as many times as you want to, because it's really easy. It all up to you is whether there's a cost involved, whether you charge for a cost. Now, this is again a study is, let's suppose that you only could do 1 field rather than even 2 or 3 fields. Well, it turns out that 1 picture of the eye, and if you had the picture of the eye with the optic nerve a little bit to the right or to the left, and you saw the complete posterior pole in between the primary arcades, you have as good a mechanism for specifying and being sensitive to the disease. So it's very good. So if you can get a good picture in the particular area, it's as good as in person. So 1 picture is very good. I usually like to suggest 2, because a lot of times you may not get a good picture in the first one. So again, this gives you a little bit of studies. So there's a lot of studies that show the wisdom or the value of taking photographs. And as a matter of fact, it's now common for regular general practice doctors or primary care doctors and internists to have cameras in their office so they can take pictures. Now, in the United States, I designed a program where that's what I do. I actually place digital retinal cameras in primary care doctor's office. Now, the good thing is they don't know how to read it, so I have them read by optometrists, and they therefore can say, well, this is not yet treatable, and we're going to, return you to the regular optometrist for either get glasses or contacts, or we say, hey, you need medication. So the value of the photograph is they can help the primary care doctor sort out where the patient needs, which patient needs the care now, which patient needs other types of care. Of course, if you could do 2 field, it is pretty close to face-to-face. So now there's a lot of different results. One study said that there was not very good sensitivity for any type of retinopathy, but if there's a serious problem that's sight-threatening, it's pretty good. So even though you may not say that it's absolutely not there, that's okay, because most people say, hey, that looks pretty bad. And so when you say that looks pretty bad, you usually will be able to not make a mistake and be able to send the person onto the doctor for treatment. So when we call that false negative. That means that a false negative means we say that you don't have a problem there, and you might get concerned because maybe the photograph wasn't as accurate as you would, and therefore you would not refer somebody that should have been referred. That's called false negative. We'd rather have a false positive, though, where we say, I think there's a problem there, and it wasn't a problem, because it's probably better to over-refer than under-refer. But still, a single field digital retinal photography photograph is pretty good for serious problems, definitely. So it certainly has its value. Now, there's a technology called OCT, and of course, OCT actually is, when it's matched with digital retinal photography for detection purposes, it's pretty good. They both match it pretty good. It's not necessarily superior. Now, the value of OCT is that it's probably better for deciding when to treat and how much to treat, which the photograph may not be as good as. But for detection of early disease, certainly the digital retinal camera is better or as good as OCT. And the last point was there are some cameras that use the phone as part of the system, and it actually is pretty good also. So it's actually compares favorably to 1 or 2 field digital retinal photography. The popularity of a smartphone-based phone, of course, is smaller and takes a lot less space, and is probably less costly. Now, in the case of, I mentioned this previously, in the pandemic, you get to stay away, you get to keep your distance from the patient, and you can still maintain a prevention program because diabetes doesn't stop because of COVID, and actually identifying somebody with diabetes may be helpful because you can say, hey, you know, if you have diabetes and you have diabetic retinopathy, please take extra care that you don't also get infected. So we call those at-risk people. So by identifying a systemic condition that could be a prelude to more serious hospitalization, that's a value in public health, is to say, look, stay away, try not to get infected. You'll never get to the hospital because being in the hospital is pretty, is costly, and usually a large proportion of people who end up in the hospital who are on respirator actually die. So therefore, and one of the leading causes is diabetes and weight. Those are 2 big risk factors for not surviving hospitalization with COVID. Now, you know, if you don't have a camera ready, you have a choice. You can say, well, I can have a handheld camera or a tabletop camera. And the value of handheld camera is that, you know, if you move from office to office, or if the patient is not in a particular chair, and you may be, like I've used the cameras in exhibit halls, I've used it like I used to go to home visits, I've used that. A handheld camera makes a lot of sense in that case. And there's no doubt about it, in those particular circumstances, handheld is probably going to always be better than the tabletop. Now, however, the tabletop does give the advantage of better and more consistent quality because the patient doesn't move and you don't move. And usually what happens is that when you eliminate the movement on the patient and on the doctor, you actually can get better quality photos. Now, one of the other values of the tabletop is you're not going to be close to the patient if you're trying to prevent infection, because a handheld camera, you're going to be right next to the patient and pretty close, even like within 2 feet. And usually when you take a picture, it takes 2 to 5 minutes. Well, that's too long. Studies show that if you suspect, you know, you have a person and you have no idea for whether they have the COVID asymptomatically, you assume everyone has it and you treat them that way. That means that you try to minimize your contact. And usually studies show that if you can stay away from the patient, don't stay any longer than 60 seconds at any one time to a patient, then your risks are going to be decreased. Longer than 60 seconds, then of course you have a run the chance. Now, there's a disadvantage to handheld cameras. That means that they're small and they're probably a little bit more fragile. And again, a lot of times, you know, the way you line up for a camera, it's a little bit more difficult to get a good picture than with the tabletop. And the tabletop, of course, is that you get better photos, but it lacks portability, and it's pretty big and it's more expensive. And sometimes, you know, now there's an alternative. You know, used to be just the expensive handheld versus the expensive tabletop. Now it's relatively inexpensive smartphone option. It's usually half or a third the cost of even the handheld or old-fashioned handheld. So this might actually become more prevalent, because if you were to take a lot of pictures and you didn't want to be able to have it in more places, it's possible that the smartphone-based camera, handheld camera, may be the way to go, because for one handheld camera, you can buy 5 smartphone cameras. So more places can do it. Now, it may not take as good a picture as a conventional handheld retinal camera or desktop, but it's good enough. And what I say before is, when you saw that 90%, it's good enough to see the most serious cases. Practically anybody can see a serious case. Again, you may not be able to say it's not absolutely there or absolutely not there, but you can say, I see that's serious and that should go. So that a smartphone phone can do. So now the environment for most retinal cameras is that, for an optometrist, is that it's best that we can do it without any dilation, because dilation adds the time you wait in the room. And I always can tell whether which eye was done at first, because usually the first eye is the best picture and the second eye doesn't. Usually you have to kind of wait about 1 to 3 minutes between the eyes when you take a picture, because when you recover the flash on the one, you got to let the other eye recover, and so that you can take a picture under non-mydriatic conditions. And lastly, to protect the patient, in the United States, we protect the patient by making sure that we don't identify the actual name of the patient. We sometimes give a random number, and we record the random number. And so the photograph itself, if it was to be intercepted or be seen, and it's not authorized observer, then having a random number does not give away the identity of the person. And at this time, I'd like to give a little bit of insight about, how do you, these are just images of picture. This is a handheld camera, and one of the ones that you probably have been out there for 4 or 5 years. The best way, what I consider, if you had one picture to take, is this one, where you see the posterior pole between the primary arcades. And yes, it's possible that you could have disease on the nasal side, but the temporal side, and using the optic nerve being the way it is, not only you can determine glaucoma, but you can also look at the complete area. And this is where my pointer, you can see that area is the most area. If you see retinopathy in this area, usually that's more important than any other retinopathy anywhere else, because this is the area where you might need treatment immediately. The same as over here. So now, this is just different types of pictures you see. A lot of the camera manufacturers will also want you to take a picture where when you line up, you see the brightest reflex in the eye. When you see the brightest reflex, you're following the optic nerve head, because that reflects 100% of the retina. But then when you take a picture, you get this. Now, when you get a picture here, that's a great optic nerve head, but because the retina, the macula is over here, you don't know whether there's disease over here. So a lot of times, well-intended training of cameras doesn't mean that you get the right type of picture. Again, the right type of picture is this picture, where you, in my opinion at least, is that where you have the optic nerve on the side and you have the central area of the retina being visible, because that's the most important reason why you take a photograph, is the macular area. You're trying to preserve that vision. Now, by doing the approach of having the optic nerve here and being able to see part of the posterior pole, even if the photograph isn't perfect, and as you can see, it's not perfect because there's a part of the lid here, and a lot of times you can't get it. This is a handheld camera. You can see because the guy was blinking, or the patient was blinking, but you can see that there's sufficient evidence that even if you couldn't see anything else, this is serious, and it really requires probably referral. And knowing the natural history of disease, it's probably going to change dramatically in 3 months if they don't do anything. So it's not immediate, it's not emergency if you see this, but it should be seen by the appropriate doctor, whether it's another optometrist or a treating ophthalmologist, within 3 months, because it probably will get worse. And again, this is another case where your picture is not perfect because it's dark, but you have evidence here that says, hey, it's good enough and I can see something, therefore it's referred. So the picture doesn't have to be perfect in order to refer a patient or to classify a patient. So this is a classification, say, this is a patient who has diabetic retinopathy, and this is a patient also. So even if the picture wasn't perfect, you can say, this is a person that can be counted as having diabetes. Now, this is not necessarily a public health issue, but it mainly is the cameras. When I said that you take a picture and maybe you didn't see it when you first looked with the ophthalmoscope, but when you look at it later on, you can say, hey, I think there's something there that I didn't notice before. Now, when you see all these black splotches in a diabetes patient, these are the old-fashioned laser burns. And they still do this if the retinopathy is so severe that injections don't work, because injections work best if there's not a huge amount of damage. In this particular case, there was significant damage, and the only way to try to save the central vision is to burn out as much of the retina as possible. This is an old case because you can see the clumping. Usually this pigment clumping is a sign of very old laser burns. But here down here, you can see that the where you couldn't see the macula. So again, if the picture wasn't good enough, but you can see here that there has been past laser burns, and usually this means this patient had diabetic retinopathy, diagnosed with it a while back. But even if you have laser burns, laser surgery, that doesn't mean the patient doesn't have diabetic retinopathy. They still do. It just means that there's less damage. So you would still include this patient as having diabetic retinopathy if you haven't seen this patient before. You know, they travel and start immigrating here. Or you can say this needs to continue. If you see this in your current practice, this patient still needs to be seen by somebody, because if the condition was serious enough to require this amount of laser burns, then you can say, yeah, this is still a serious case. And here's again, this is another type of laser burns. You can see the way it's arranged around the particular macular of the area here. Again, this is meant to save the eye. Now, because the image is darker, it doesn't have this type of photograph because it's darker, and so therefore you're not sure exactly what the in-between pigmentation, but it's enough to show you that if the photograph was better, you'd probably have something similar to this. Now, you know, some of the other things that you might see in a photograph is these little white spots. Of course, that's vitreous opacities. And you can tell because they're literally over the vessels and they obscure the vessels, so it's a media effect thing. And a lot of times in certain individuals, this may be a sign of a break in the retina. But in this particular case, because it's both eyes and equal intensity, you can say that this is probably age-related. But if this was in one eye only, I'd be suspicious that there could be a reason for some type of retinal break. And of course, there are other conditions you can see. Just an example of you know, bleeding in one area, and you can now see it in this area. You can actually say whether it's mild, moderate, and severe just on how many places it. So I usually like to say if you divide this photograph into a square, 4 quadrants, you can see here that this is in 2 quadrants, and here it's in the same things in 2 quadrants. Usually in time you have 2 quadrants per eye, then we call that moderate eye disease. And anytime you have moderate disease, you usually should refer to an eye surgeon for additional care observation. Now, there are, of course, there are other conditions you can see that are not related to diabetes. This is a condition where you have high myopia or coloboma of the back of the eye. That means that the optic nerve did not close correctly at birth, but this is not related to diabetic retinopathy. Sometimes you can get things that are like pearly globes here, that's drusen into the optic nerve head. Sometimes, as you can see in this case, this is macular degeneration associated with myopia, because these are some early pigment changes. And again, this is looking at optic nerve for glaucoma. You know, glaucoma in the United States is a concern, but you know, it's only 1 to 2% age 40. So diabetes rate is about 5 times that. So it's going to be more common to see diabetic retinopathy, but you do get a chance, like I say, if you take a photograph and you say, oh, I'm going to review it, look at that later. Hey, he says, by the way, I missed it. You know, this optic nerve head looks bigger than this one. This is the same person. So I'd say, okay, this probably may be maybe it's a risk for glaucoma. If you have the right equipment, you can say, no, it's not, everything's fine. Or you may need to refer if you need to have better, to get a better result. But this is a situation that probably needs additional testing or referral. Again, this is just a different type of picture. You can see that these are pictures of some type of changes. Now, this is because these are laser burns most likely, and these are laser burns are old. These are done at different times. Now, these may be more recent, but they didn't require as extensive. So we call that usually grid, where we're trying to do we surround whatever lesion we have with burns. Here, the situation is more extensive, where there is, you know, we really are seeing a much larger area that needs to be lasered. And so this can tell you exactly the course of the disease. These 2 laser treatments did not seem to be occurring at the same time, and that means they're progressing in this case. Now, again, when we talk about, you know, Can we see other parts of the retina? Of course, just by moving the eye slightly, you can see it. But again, if you do that, and that's your sewn picture, then in this case, this is the area of concern right here, where the temporal eye, this is where we need to see, then we lose that particular value. Now, that doesn't mean that the picture is worthless. It just means that we'd have to be much more attentive care. Now, you can actually see a lot of retina here, and you can see where the vessels are. And again, if you see any conditions in 1 or 2 quadrants out of 4, that will give you a little bit of severity. Even though you couldn't see here, let's suppose this top half cut off, if you see particular abnormalities in 2 fields here, that would be enough to refer and to classify because it's good enough. So you can also think about what kind of risk factors. Here's exudate and there's hemorrhage. If these 2 areas are right in the center of the eye, then our urgency to refer is much higher. Usually when these risk factors are outside the principal arcades, it's not as urgent. But again, the area here is very, very possible. That's where the OCT might be helpful, because usually edema is not visible, but we've always been taught that any type of white spot near the macula is presumed to be macular edema until otherwise proven. Again, the presence of dots around the macular area, this is the macular area, we presume that's sight-threatening retinopathy that has macular edema. And in the old terminology, this was used to be called clinically significant macular edema. In the last 5 years, we call this macular edema with involvement of the macula. So even if there are bleeding or white spots, we still say it's involving the macula. So when you say involving the macula, the treatment referral actually rises, the urgency. So if this particular white spot was someplace else, like out here in the periphery, and we would call that retinopathy not involving the macula, that means sometimes we can actually observe it because you're not going to lose your vision. And we wait until it gets sight threatening, then we do treatment, because no treatment has no risks. Every treatment has a risk. So what most eye surgeons will do is they want to start treatment when it's the right time and when the benefits outweigh the possibilities of danger of bad outcomes. Now, again, this is just an idea of what are some of the possibilities of sight threatening. This is called epiretinal membrane because you can see the reflectivity. It's not to be mistaken retinopathy. This is a great picture of that epiretinal membrane. It's a little membrane that's on the back face of the vitreous that will attach itself to the macula. In some cases, it can cause retinal holes because once that vitreous completely detaches, sometimes it will tear up some of the underlying retina out, and this is actually macula involving, and so therefore it would be a potential problem. If you saw a little red spot or a little black spot in the center of this, that means there is a forming macular hole. But you can see the value of getting as good a picture you can between the principal primary arcades, because this is the area of the greatest interest. And again, this is another picture of other sight-threatening retinopathy, and again, even if you could only see one eye and not the other, the value of the photograph is still for classification purposes. So I usually like to say is, if I see this, it doesn't matter what this looks like, because even if it doesn't have or it doesn't have, this is sight threatening because these are within the very close to the macula and they will refer immediately. I don't need to know what this is. Now, if this was outside over here and it wasn't, and I couldn't see on the other eye, I'd say, based on my experience, I don't think I'm going to refer. I'm going to wait until, I get a picture again or otherwise. But if you were doing a public health service and there was nothing here, like this was clean and you had this particular clarity, I would still say this person has a low risk for retinopathy, because usually the high risk for retinopathy is it's obviously there. So even if you put this white spot in there, you would obviously still see it. Even though as blurred as it is, it might be due to cataract, but you can still see the whiteness underneath this. Lastly, I want to go over a little bit about what kind of cameras you want that are visible. This is actually an Indian camera called the Forest camera. I've actually deployed this in the United States at least quite a bit. It's durable because I was most impressed with the fact there's a photograph of this camera in its case at the back of a scooter as it rides itself around its various clinics. Now, I don't recommend that, but evidently they tried it out and it actually worked. Now, the table is included, but this is a case. There's a suitcase that's tied to the back of a scooter. Now there's a bigger, more exotic fundus retinal cameras. These are the traditional tabletop cameras. These are what we call the fundus or the smartphone-based cameras, which are different from the mobile cameras. There are mobile cameras. I couldn't get a picture of the regular traditional handheld camera. So this is just the picture that someone loaned me that are the ones that relate using the smartphone. And these are less expensive. You can see how portable it is. Now, you could mount this on a stand, but most times it's not. It's usually freestanding. But in this case, this particular company, I have no relationship with this company. The only reason I use this company's images is they lent it to me and gave me rights to use it. So if I had rights to use it otherwise, I would probably use others, give other examples. Again, this is what a smartphone camera is. This is what a regular tabletop. In between is a traditional handheld camera that uses this technology rather than a smartphone. And I am open to any written questions. I'm not sure exactly how that's done. If there's a chat box, I'm willing to answer questions, or you have questions. Otherwise, I can be contacted. Please connect with me in these various ways.
Okay, thank you so much, Dr. Richard, for such a wonderful presentation. Now we are to move to our discussion session. Are you ready to take the questions, Doctor?
Yes.
Yeah, I will be reading out the questions for you. Okay, we have our first question. How to diagnose diabetic retinopathy in patients having opaque media due to cataract or vitreous hemorrhage?
Ooh, you have to repeat that question again.
Okay, doctor. How to diagnose diabetic retinopathy in patients having opaque media with cataract or vitreous hemorrhage?
Okay, so usually the cataract is going to be 75 to 80 years old, and when it's serious. So therefore, you do it by age. You say anybody under the age of 65, 70, you should be able to take a photograph easily. And even if the cataract was in the way, that's one of the things I can see, told you about, is even if the photograph wasn't clear, a really bad problem is pretty visible even with a cataract. So it's pretty obvious. Now, there may be subtle signs, such as a little bit of bleeding here, a little bit of white spot there. It probably, you can't see it through the cataract in the photograph. But again, if it's white and there's a lot of it, it's pretty obvious. And even through a cataract, you can see. Now, you can't see it though. If you ask the person and they only have counting fingers with a cataract, of course, you won't, there's no use even trying to do a retinal photograph or any type of fundus examination, because you can't see in. If they can't see out because of the cataract, you can't see in. So therefore, in most cases, you're correct. You can't diagnose or detect retinopathy in a dense cataract. But again, if you pick the choices of making sure that you evaluate everybody under the age of 65, then you probably can detect. Now, I personally run a program where the average age is 69 years old. And only 20% or 25% of that population, I have over 16,000 people now, have sufficient cataract that the photograph is impossible. Well, that doesn't mean that I forget about the other 80% that I just took a photograph of, 75%. That's value, because at least I don't have to send those patients to the scarce resources of the eye surgeon. So in other words, the eye surgeon doesn't have to, or you, doesn't have to their time doesn't have to be taken up with people who have no need to have treatment immediately. So we can say that even if there was no cataract, refer them in away, because they may need a cataract surgery. They may not have diabetic retinopathy, but need cataract surgery. Both are conditions which can cause vision impairment. On the cataract, it's preventable, it's treatable, and retinopathy is not so. So I would say you can't, but I refer them in a way, because in either circumstance, they would need treatment.
Okay, doctor, we have our another question. How can we get three-dimensional image if we need?
Could you repeat that again?
Okay, can you see the questions on chat box?
Let me see. Oh, here I could see the question. Okay, really? Okay, good.
Yes.
Oh, how to get 3D image if you need it? Well, we call that stereo. So usually you can. I can see that. Okay, so um, in order to do a 3D camera, you would have to be able to take two pictures, usually in two different axes, and somehow meld them together. Now, I don't think I could tell you how to do it. I've never actually considered it, so I'm not exactly sure why we would want that, because it's, when I do a vision, when I roll out a public health program, I usually don't consider 3D is important. And I only have a certain amount of time to see the patient. So therefore, I know a 3D image will eventually take longer. So we have, for the instrumentation in the field, I don't think the instrumentation is there yet, or technology in that small of a package. So I can't tell you how to do it, in other words, and that's because I wasn't interested in that, in doing a public health vision program. So it may be great for your own patients, but for a vision, for a public health vision thing, it's not necessarily what my interest would be. Okay, someone's talking about diabetes. Actually, this is how do you take care of or prescribe glasses in uncontrolled diabetes? That's a tough question. In the United States, sometimes we prescribe 4 to 5 pairs of glasses to the patient. And what we say is the prescription might change, but if your blood sugar goes up, you look for the pair of glasses that works. So sometimes if a patient is unable to control their diabetes, then don't just prescribe 1 pair of glasses, prescribe 4 or 5, have them come different parts of the day where the blood sugar will be different, and then prescribe it for that day, for that particular time period. And most people who have diabetes will follow a particular diurnal pattern for their vision, because that's the way they eat. And so therefore their blood sugar will go up and down. So their blood sugar upon waking will be much more different than after 4 or 5 or 6 hours, or just before bedtime. So again, I would consider prescribing more than 1 pair of glasses. But you're right, it is difficult. And a lot of times you can also do this until your blood sugar is stabilized. You can come back and get a prescription to get the glasses. But I usually tell the patient that you ought to have 2, 3, 4 pairs of glasses. And in a lot of circumstances, they don't argue because they know they can't control the diabetes. So I hope that answers that question. What happens if you have intraocular pressure and a DIS ratio of 0.5? Well, the good thing about glaucoma is this, and I think that is a risk for glaucoma. Now, it depends on your laws in your country and what kind of the scope of practice. But in the United States, the definition of glaucoma, it has to be progressive. In other words, if you get a large optic nerve head and you see the intraocular pressure being under 24, in the very low 20s, that does not automatically mean you refer, because glaucoma by definition means that the next time you see the patient, maybe in 6 months or maybe in a year, you say there's a change. That's why the photograph is actually kind of nice. You can say, a year ago, I saw and took a picture of that eye. This year, I take a picture of the eye and look at how different the optic nerve head looks. That's glaucoma. Now, the good thing about glaucoma, it takes 10 to 20 years to go blind. So even if you say somebody wasn't glaucoma and you caught it 1 year later, yeah, you can test for the difference, but that doesn't mean that difference caused damage. In the United States, it has to cause damage before you're really blamed. So again, it depends on your laws, whether you have to automatically refer that, but usually what happens, you need to change. So that's the value of a photograph. You can say, and accurate records, you can say, this is what it looked like a year ago or 6 months ago, and this is what it's now. You can say there's no change in the look, and then the pressure is the same, and that means the eye has been the same. So that's how I use the photograph, is to say, look for a change. I don't think I would refer somebody just on the information you said. Now, there is a pressure reading that automatically you refer regardless of the retinal finding, and that's 35, 36. If you have a pressure over 35, 36, that's automatically you refer that patient, regardless. So you're assuming, one of the questions is, which lens can we use on the iPhone for retinal photography? Well, The assumption is that you can buy a lens and just attach it. Well, you actually have to buy the most common types of phones attachments for the actual retina. Very simple. It's like you may attach a lens. That's what most people want because you have a phone already and you buy a lens. Well, the attachments, there are some that are available, and some of them are mimic what we call the Welch-Allen approach to their particular ophthalmoscope, which is a 20 degree field lens, and you can attach it in the back. So most commonly, you can't buy a lens that's real small that attaches on a camera to be able to see. Now, I believe that it's going to come out, because public health is important. And if you can give the lens to 500 people who are in the field and take pictures, then that's what's necessary. So I don't see that right now in production, but I believe it's going to occur. But again, we have to wait time because probably there's not a lot of money made in small lenses for cameras. Most of the money is by big machinery, right? So you have to have somebody, and this is a person that can fund a public health program. Hey, the condition is bad enough, no one's doing it. We should be doing it, and donate the proceeds to the community, donate it to the doctors who actually are needing to do it, because then we have more people. In fact, give it as a way for even lay people to take photographs and then send the photographs to be read. So again, I don't think I see a lens at this point that can simply attach it. There are much bigger attachments that attach to a phone, but then it's pretty big. So I hope that answers the question, that there is none right now that I know of.
Okay, thank you so much for your answers, Dr. Richard. These are only the questions that have been raised by our attendees till now. I guess we have answered almost.
Yes,
Yeah.
I just want to ask one. I just want to answer the question one more way. Let's suppose you have vitreous hemorrhage and you can't see anything. Okay, so I don't know if you have a transilluminator, but sometimes you can do something like a very gross test. You can use your, transilluminator is great, or you can use a very sharp, very strong flashlight, small flashlight, and you can actually use the flashlight and press it against the lid, and you can say, do you see the light? And you can do it under various areas. If you can do that, you can actually say the retina is intact. Because if the retina was off, you wouldn't be able to see the image of the light in all the quadrants. So that's just one of the kind of like a tip, that if you can't see anything, at least shine any small pen light you have against the eyelid, all the various areas, and you can say you ask the patient, do you visualize light? And how you record it is the pen light was visualized through the lid in all 4 quadrants. Then that's actually very helpful. So I just want to leave that. I forgot to say that.
Okay, thank you so much, doctor. Well, I guess we have answered almost all the questions till now. Considering the time limits, here I announce the closure of discussion session. And I would again like to express my immense gratitude towards our presenter, Dr. Richard, and to all the attendees for their endurance. Also, I would like to thank all the direct and indirect helping hands for the iTalks program. Before wrap up, I request our today's presenter, Dr. Richard, to share his few words to our program.
Thank you, and I appreciate the chance to give this course, and I maybe want to be able to do it again next month or periodically. But of course, I have a kind of like a vision public health area and may not necessarily apply, but I practiced for 30 years, so I'm pretty familiar with various forms of practice, although I don't have courses that are designed for that. So again, I appreciate the chance to talk. I'm always willing to talk about optometry, wherever it may be.
It's our immense pleasure to have you with us today, Doctor, and we love to see you in the future too.
Okay, great. And by the way, I applaud the individuals involved in doing this, because, yeah, why not create something like this in your spare time?
Thank you, Doctor. Herewith, I announce the closure of today's webinar, hoping to see you all again tomorrow. Stay safe, stay connected. Thank you.